Hi, I'm Lauren,
Hi, I'm Avery.
and we did our project on a patient with a triangular fibrocartilage complex lesion.
Okay, our patient's name is Tony. He's a 25-year-old male car mechanic. He's been working at his father's shop since he's graduated high school, so around 7 years now. In his free time, he enjoys playing pickup basketball with his friends. He hasn't had any specific mechanism of injury. However, because he uses his wrist and hand for over 9 hours a day, he's had chronic pain for around 6 months now, and he's also right-handed with all of his activities.
So TFCC lesions can either be caused by a traumatic or degenerative MOI. With an acute MOI, it's generally from falling on an outstretched hand, some sort of a forceful twisting or pulling motion. You can have a traction injury to the ulnar side of the wrist. It's common with power drill. People who use power drills can get this injury, and with a distal radial fracture. Degenerative causes that cause wear and tear on the TFCC are either from repetitive pronation motions, some over time with gripping with load or force, and if your radius is congenitively shorter than your ulnar, making your ulnar longer.
Okay, some signs and symptoms associated with TFCC are typically pain on the ulnar side of your wrist, so your pinky side, clicking and snapping associated with wrist movement, weakness and instability are also associated with the TFCC lesion. Typically, the patients have pain with turning door handles, things such as lifting heavy objects, as well as pushing themselves out of a chair. They also have reduced grip strength and tenderness and swelling over the dorsal ulnar aspect of your wrist. And there's sometimes signs of trauma such as bruising, and then there's usually limitations with your work.
So the TFCC is located on the ulnar side of the wrist. It kind of helps hold the radius and the ulna together. It's a triangular shape, hence the name, and it's made up of several ligaments and cartilage. It sits between the ulna and the two carpal bones, the lunate and the triquetrum, and the central 80% of the TFCC is avascular, which leads to poor healing properties.
Okay, so the functions of the TFCC, it acts as a main stabilizer of the distal radial ulnar joint. It also contributes to ulnar and carpal stability. It also allows for cushioning between the forces transmitted through the ulna and the carpal bones, such as the lunate and triquetrum. It provides a flexible mechanism for stable rotational movement of the radial carpal unit, and it allows for wrist movement in all 6 directions: flexion, extension, radial and ulnar deviation, and pronation, supination.
Some rehab approaches, you can go non-operatively and a conservative approach. If your wrist is more stable, this is generally how they would start you out. You would start out immobilized and splint for about 4 to 6 weeks. You would begin with progressive range of motion and light strengthening exercises. You can get steroid injections to help with the pain and the inflammation during this time. Generally, conservative approaches are going to have a quicker progression, and so you can return to play within about 4 to 6 weeks. If your wrist is already unstable when you come in, and the immobilization from the conservative approach for 4 to 6 weeks was non-successful, you're going to go ahead and be suggested to have surgery. If you come to us post-op, we're going to be concerned with edema control, pain, and tissue healing, and you can return to play in about 5 to 8 weeks.
Okay, previous treatment, Tony underwent an arthroscopic debridement. This is performed by draping of the wrist. You have assisted suspended wrist by a finger trap traction, such as in the picture right here, as well as small puncture wounds found on the dorsal aspect of your hand and wrist. The arthroscope is going to be placed through the radial carpal joint, where the TFCC is then going to be probed together. Immediately after this operation, you're going to be wearing a compression dressing and a volar wrist splint, and he's coming to us 3 days post-operation.
So in Tony's initial eval, he complained to us of having pain out of a 6 out of 10 with all wrist motions. He had 4 out of 10 pain at rest. We measured his range of motion for ulnar deviation and found it to be about 35 degrees, which is lacking 10 degrees of motion, and he had radial deviation of 12 degrees, which is lacking about 8 degrees of motion. His grip strength on his left hand or his uninvolved side was 62 kilograms, and on his involved side or his right side, it was about 54 kilograms. We performed manual muscle testing. On his left side, his elbow flexion was a 4-. His elbow extension was a 3. His shoulder extension was a 3. And his shoulder flexion was a 4-. His left side was all within normal limits.
Okay, for our first phase, the inactive phase, this was before Tony came to us. So he was taking NSAIDs for pain. He was also performing the Price method, as well as splinting and immobilization. Typically during this phase, we don't do many exercises because we're mainly focused on initial healing of the wound, as well as reducing the pain and swelling.
So in phase 2, we're going to be focusing on range of motion. Our first short-term goal for Tony will be to have him have 42 degrees of active range of motion for ulnar deviation by the 3rd of April. Some exercises we're going to give him for this goal are towel slides and hammer hold pronation supination. Towel slides. Patient radially and ulnarly deviates and holds for 5 to 6 seconds. Uses towel to help assist with motion.
Okay, and for our second goal, the patient will increase grip strength on the involved side to 58 kilograms as compared to the involved side of 62 kilograms. By doing this, we're going to have him perform putty full grips as well as sand grabs. Putty grips. The patient's going to squeeze the putty and hold for 5 seconds, and then relax and then squeeze again. Sand grabs. The patient reaches their hand into the sand, grabbing an object, squeezing it, and then placing it back into another thing of sand.
In phase 3, a short-term goal for Tony is going to be to maintain 90 degrees of shoulder flexion, and with his elbow flex, string a PNF for the mixed stabilization for 4 sets of 10 seconds by April 17th. To help him achieve this goal, we're going to give him some body blade exercises and wall ball stabilization. Wall ball stabilization. Patient moves their arm on the ball to get full range of motion in each direction.
Okay, for our second goal, the patient will improve their strength to 4 out of 5 with elbow extension by the 21st of April. We're going to have him do this by doing resistance band bicep curls and tricep curls, as well as tricep dips with a Swiss ball. Bicep curl. Patient holds TheraBand while flexing the elbow and then slowly extending the elbow. Tricep extension. Patient holds TheraBand while extending their elbow and then slowly flexing their elbow. Tricep dips. Position your hands shoulder width apart on a secured bench. Slide your butt off the front of the bench with your legs extended out in front of you. Slowly bend your elbows to lower your body towards the floor until your elbows are at a 90-degree angle. Then extend your elbows fully while pushing yourself back up. Progress from a secured bench to a Swiss ball to incorporate proprioception.
In the 4th phase, we're going to be a little bit more aggressive with plyometrics, functional, and specific activities. Our first short-term goal for Tony is going to be to have him maintain balance on a single leg while dribbling a basketball for 1 minute on an even surface by the 28th. Of exercises we're going to give him for this are single leg rebound ball toss and double arm dribbling. Single leg rebounder ball toss. Patient stands on one leg while using the affected arm to throw a ball into a rebounder and catch it. Double arm dribbling. Patient uses both arms to dribble basketballs while walking for 20 feet.
And our second goal is that Tony will be able to perform overhead pronation supination for a total of 2 minutes. Exercises for this will be overhead wall chest passes as well as overhead press. Overhead wall pass. Patient starts with ball above their head and rebounds it. 3 sets of 15. And this is our citation page in the end.